Hello, good morning. I'm Caitlin Houghton, and I'm talking about advancement of hiatal hernia repair through innovation and collaboration. These are my disclosures. So the objective of the talk is to discuss the role that innovation and collaboration has played in the advancement of hiatal hernia. When I thought about what I was going to talk about, I thought about a famous quote we've all heard. If you don't know where you are, then you don't know where you, if you don't know where you came from, you don't know where you are. If you don't know where you are, then you don't know where you're going. So in this talk, I'm going to talk about three main points of where we've come from and how we've evolved over time. I'm going to start with a little history lesson in foregut. So really, foregut surgery and hiatal hernia surgery started with a debate between two surgeons, Dr. Nissen and Dr. Allison. Dr. Nissen was all about the LES. You just needed a gastroapplication, you can do it all through the abdomen, and the bulk of the Nissen is going to prevent the hiatal hernia. Dr. Allison was all about the hiatal hernia. You just needed the crural closure. You can do it all through the chest, and you don't need that crazy wrap thing. Well, modern science and innovation have led us to several conclusions. With advanced pH monitoring, this allowed for objective measurements of our outcomes. We no longer just had to rely on patients' symptoms and endoscopic findings, but we were actually able to quantify how our surgeries were affecting these patients. And we've learned that patients that get the fundoplication and the hiatal hernia repair actually do better and have better control of their reflux than doing either one alone. High-resolution manometry shows contributions of the LES and the crura are distinct. The barrier to GERD is both the crura and the LES. The LES giving length to your barrier and the crural repair adding pressure to your barrier. And then 3D computer modeling has really shown us the anatomy and the contributions functionally that both the LES and crura are making to our repair in hiatal hernia. So modern science and innovation through science have allowed us to confirm a two-barrier theory. We don't need to follow just Allison or Nissen, but we need to combine their approaches. We need to pay attention to both the crura and the LES augmentation, and surgical intervention must combine both components. Next, hiatal hernia repair was really based around the Nissen fundoplication. We had one tool that was good for everyone, and that is what we had been doing for generations, and that's what everyone needed. If you had acid reflux, you needed a Nissen. But with innovation, we now have multiple ways that we can augment the LES. And we can really personalize our approach to what the individual patient needs. So now we not only have a fundoplication or the Nissen, but we have endoscopic options. We have TIF, which is transoral incisionless fundoplication, and we have new injectable agents that are going through FDA approval trials right now. And these are really used for patients who already have integrity of their crura, so we don't really need to augment that portion of their anatomy all that much, but they need LES reinforcement. And we can do that endoscopically now and not subject our patients to a surgery that maybe could be overkill. However, if they do have displacement of their crura and need their crura reapproximated, we have surgical options as well. Not only the Nissen fundoplication, but we have endostim and Lynx device, which is creating a two-way valve instead of the one-way valve that we're creating with a standard fundoplication. Not only that, but robotic innovation in our technology has led to robotic surgery, and the advances of our technology and allowing us to perform the operations in a different manner. Really, robotics gives us better visualization, better ergonomics for the surgeon, and hopefully better outcomes as we study it further. But the advantages are giving more autonomy to the surgeon themselves. We no longer have to rely on someone to be retracting appropriately or showing us what we need to see in the critical spaces in the mediastinum, but we can control that all on our own. And we have better instruments that we can continue to innovate and continue to work with technology to improve our techniques. And lastly, we've been talking about this, but we come from a society of competition. Surgery has always been operating in silos. So we always blamed the outside hospital for the complications that walked through our doors. It was always someone else's fault, never our own. And we competed with each other. What if you were fellowship trained under Swanstrom or Pellegrini or Horgan? There's different lineages, and we knew that my approach was going to be different to yours, but mine was better. But now with collaboration, we have the IHC, we have robotic hernia collaboration, and the SAGES, Masters of Foregut. Now we're able to get real-time opinions and advice from people that have all different perspectives and have been trained through different perspectives. So I can see that my colleague is doing 30% cholecystoplasty and I'm doing none. Well, what's the dichotomy? We have the same patients. We're both in LA. So there must be a middle ground. And maybe we need to combine our thought processes to really evolve. The IHC, or these online forums, are leading to more questions, more online advice, immediate advice. But not only that, they're leading to really more personal relationships as well. So it transitions from just being an online forum to really creating personal mentorship and professional mentorship relationships, not only advancing your own personal skills, but then also leading to a family of surgeons across the nation, not only in the walls of your own hospital now, able to collaborate and really see what everyone's doing across the nation and internationally as well. So how has foregut surgery advanced? Well, we started with a debate between two surgeons trying to outprove each other. And innovation through science has taught us that a combination of techniques really provide the best outcomes. We started with dogma, treating patients the way they always had been, one surgery fits all. But through innovation with technology, we've allowed for personalized surgical therapy with more advanced tools, allowing for better visualization in ergonomics, and possibly even better patient outcomes. We started in silos, always blaming the outside hospital, and through innovation and collaboration, that helps us to maintain quality within our field by challenging our thought processes and providing ongoing advice and mentorship. Well, where are we going? I think as in the future of foregut surgery, I think that we need to have more national registries. I know a lot of areas in surgery have big national data spaces, and foregut is kind of lagging behind, so we need those databases so we can have high-powered studies and we can really prove which techniques are going to be the best. We need to continue to embrace new technology, but not only embrace it, but study it and see the impact that it's having on our patient in our clinical practice. More advanced networking capabilities with remote proctoring really is allowing us to transition from only having mentors within your hospital, but across the nation as well. And then video scoring devices, which are going to help us maintain quality in our field by allowing us to have an objective measurement of the quality within our fields. I'd like to thank you.